The approach for perioperative therapy is complex. I think that's one of the main questions that my fellows and even other physicians, sort of come to me about in terms of how we would do this. And I guess I would begin by saying that there's not one dogmatic correct answer. I have many colleagues in Europe where for, distal esophageal cancers, proximal GE junction tumors, the preferred approach is chemotherapy and not chemoradiation, which is what we would tend to do here. And for many people, for distal gastric cancer, even at very elite centers, they prefer to do neoadjuvant chemoradiation instead of perioperative chemotherapy or postoperative chemoradiation. So I guess I would begin by saying that there isn't one dogmatic standard approach for everybody. That being said, for gastric cancer, for most patients who are locally advanced, and by that I mean by ultrasound T3 or greater or node positive, my preferred approach would be perioperative chemotherapy. If they're really quite robust, then I would really try to do the FLOT regimen based on Bertrand's FLOT4 study. But for most patients, they're really getting a platinum and 5-FU in the perioperative setting. We're in fact studying the addition of pembrolizumab in this setting, and that's being tested in a registration trial internationally. For GE junction tumors, I think that's where the kind of differences are most wide. In my practice, for proximal GE junction tumors, where the surgical anastomosis is could be high in the neck, I really am more apt to do neoadjuvant chemoradiation because it's really hard to come back with radiation in a postoperative setting where the anastomosis is high because the field for radiation is really high. For most GE junction type 1 tumors, I certainly do chemoradiation in the neoadjuvant approach. For most GE junction type 3 tumors, which are really gastric cardiac tumors, I treat them more like gastric cancer, so that narrows the GE junction to now type 2 tumors. And for those patients, I really think that both chemoradiation and chemotherapy in the perioperative setting give similar benefit in therapy. So I think that's where the multidisciplinary clinic helps a lot. At our clinic, we have both thoracic surgery and general surgery. So we are able to discuss sort of the surgical nuances that may play a role in whether we should do a chemoradiation approach or not. And then also the patient plays a role as well in thinking about what they want to do. Some patients really don't want the radiation. Some surgeons don't like the radiation. Alternatively, sometimes patients and physicians prefer radiation. The question about adjuvant therapy comes up sometimes. So again, if we identify patients as locally advanced, we prefer a perioperative approach. About 30% of patients just don't recover well enough from a gastrectomy to receive adjuvant therapy. So that's one main reason that a perioperative approach might be better. But if someone had surgery and had locally advanced disease, then the question of adjuvant therapy comes into play. There are two main standard options. The standard option that I think is preferred in the West is chemotherapy and radiation. That's based on McDonald's study. That's already 2 decades old. The data from the East, Korea and Japan, look at adjuvant chemotherapy. And so that can be an option as well, but I look closely at the patient population. So in the West, the patients were more Caucasian, more obese, more comorbidities, and have survival outcomes similar to my patient population. So I'm more apt to do chemoradiation. There may be some patients who are new immigrants from Asia that I prefer chemotherapy. There are patients that won't tolerate chemoradiation, and in that group I do chemotherapy as well.